Welcome to the second AHP session of the day and to my other chairs, Ms Sarah Ajaz and Dr Simon Kopak. I take great pleasure in introducing Dr Alex Miras, who works in another high-volume centre across the other side of London from us at Imperial College. Dr Miras is a senior lecturer and consultant in endocrinology and obesity medicine, focusing his clinical and research work in obesity. Particular interests are the mechanisms of action of interventions for obesity. Without further ado, I'd like to invite Dr. Miras to begin presenting obesity pharmacotherapy before and after bariatric surgery. Over to you.
Thank you, Sarah. Thank you, Rachel. Thank you, Sarah. Thank you for the invitation. I hope you can hear me and see my slides. So good. So we'll be talking about medications before and after obesity surgery. There is some overlap with the presentation I gave yesterday to the surgical stream of the conference, but that's fine. What we will do is we'll discuss a little bit about obesity pharmacotherapy, but also about diabetes pharmacotherapy and how this can be used before and after surgery and what the evidence is, which isn't a lot, I must say. These are my disclosures. So I am an endocrinologist and an obesity physician, and many of my colleagues over the last 10 years have only been able to prescribe orlistat for obesity, which is a bit sad. And it means that rather than us being major contributors to the team, we were a little bit observers. We were looking after the lifestyle modification pathway, but we didn't have much to give to our patients in terms of the biological therapies. And this demonstrates the successes and the failures of pharmacotherapy over the last 20 years or so. But now things are changing, and what we need to understand is that things are changing very, very rapidly, which is something that I wasn't expecting, but it's very good for patients. So you will be familiar with this slide, perhaps, which shows the effect of the only other medication we have now for obesity in the NHS. Apologies for those that are coming or listening rather from abroad. Some of these will be UK based, but I'm sure there will be parallels where you are. So this is the Saxenda scale obesity and pre-diabetes studies, which showed that liraglutide at 3 milligrams can cause about 7 to 8% weight loss. And what you'll see is that when the medication is discontinued, there is almost always weight regain. And GLP-1 receptor agonists, which is what liraglutide is, are working, of course, through stimulation of the pancreas to produce insulin and bring blood sugars down. But in the case of obesity, they work in the brain, which is responsible for the disease, and that is the hypothalamus. So they decrease hunger, they increase fullness, and therefore people eat less and lose weight. And now we have got the nice guidance in the UK, which has made it mandatory for Saxenda to be offered to patients with obesity in the NHS as part of a tier 3, as we call it in the UK, lifestyle modification program. But there are very specific characteristics that make someone eligible for this medication. And the reason why this has been done is because this is the only recipe that makes it cost effective. If we start giving it to everyone, unfortunately, it loses its cost effectiveness, and NICE would not have approved it otherwise. But it is a very positive change, and these are some of the reasons why. So we do know from a very nice, relatively recent modeling of risk that the higher someone's body mass index, the higher the risk of mortality after obesity surgery. So the question, therefore, that arises is that if we bring weight down with whatever means before an operation, would that have a positive impact? And there have been some work that has been done on this in the past with, I must say, some discrepant results. But here you're seeing the largest assessment of this question with hundreds of thousands of patients And what you'll see is that even small amounts of weight loss can actually reduce not the risk of complications, but the risk of death after bariatric surgery. So I'm therefore making an inference that whatever we use to achieve that would be good for the patient. When it comes to now actual complications, the literature is a little bit mixed, and happy to take comments from my surgical colleagues, but it looks like intraoperative outcomes or length of stay is not affected by previous weight loss. But when it comes to post-operative complications like a leak or a deep infection or a wound infection, it appears that weight loss before the operation reduces that by the numbers that you will see on the graph. So probably it's a good thing to do if we can. Even if we can, it doesn't mean that the operation cannot take place, but it is always good to try. So the thing that, as I was saying throughout this week in a number of meetings, was that what Saxenda, the introduction of Saxenda in the NHS does is it gives us options as doctors and clinicians, but it also gives options to the patients. So a patient may start on the lifestyle modification pathway and carry on taking the medication for 2 years because they are happy and they are responding well. Or they might decide to go across to the surgical pathway if they feel that they want an operation would be better for them because of how they have responded to Saxenda. And someone who is already on the surgical pathway can cross back to the lifestyle modification pathway because they decide, well, maybe this is not the right time for an operation, and I will try this medication and see how I go. So the problem that we've had up to now, which is very, very limited options, appears to be gradually getting better. And as I was saying, it is getting better very fast. So look at, I think this is a nice graph which shows what can be achieved in terms of intensive lifestyle therapy here with a yellow ribbon of about 5%. We've got bariatric surgery here between 25 to 30%. And you'll see over the decades, not much going on. And then suddenly we have Liraglutide coming out in 2015 in the market, that is, and now we have it in the NHS. And look what's happening between 2015 and 2021. Semaglutide 2.4 milligrams, which causes about 16% weight loss, will be available to us next year, hopefully, in the market at least. We'll see whether it will be available in the NHS. And by 2025, through the combination of some of the medications that I will talk about, we will be able to cause on average 25% weight loss, with some people losing very similar amounts to what surgery can achieve. So very briefly, just to go through these medications that are either available or coming out in the market, we have semaglutide, which is a bit like liraglutide as a GLP-1 analog, but instead of giving it once a day, it's given once a week, which is great. We have it available for the treatment of diabetes at the 1 milligram dose with excellent results. And this is the beautiful study produced this year from John Wilding and a multinational group, which shows, as I was saying to you, the 16 mean weight loss. With what I would like you to look at is here, this graph on there at the bottom right, which is the categorical weight loss, more than 5, 10, 15, 20% weight loss on the medication. And what you see for the first time ever in the medical literature is that now we have a column which is over 20%. We never had a column of over 20% because no one ever achieved it. And now we have got 35% of people achieving more than 20% weight loss, which is just incredible. This paper came out only last week. This was on cagrilintide, even I cannot pronounce it easily, which is an amylin analog. Again, not only improving diabetes but causing weight loss, and this is a phase 2 study which shows about 11% weight loss of cagrilintide on its own. It doesn't take a genius to imagine that if you can combine the both, you might be able to achieve, as I was saying to you earlier on, more than 25% weight loss. These medications are not yet available, but they will soon be. Now, in terms of a question that I get asked very often is, should we be improving people's blood glucose before an operation if they have diabetes? And I'm jumping back to the diabetes aspect of the talk. And the answer is we don't really know. We have done some studies here. Other people have done discrepant results. So we don't have a very strong signal to say, absolutely, we have to do it. But it sounds like a good idea based on other operations in the literature, non-bariatric surgery operations in which glycemic control is probably a good thing to do before the operation. In terms of what you can use to achieve that, and that I'll jump from this slide back and forth, you can use whatever you want. Any medication you have, throw it at the patient to improve their blood glucose control. This is just a guide that we diabetologists have from the American Diabetes and the European Association for the Study of Diabetes. These are the most recent guidelines, and NICE will produce some guidelines later on this year. So the important point to make here is that if you have thrown everything you have at the patient and the glucose control is not improving, then you cannot keep torturing the poor person. Just allow them to have the operation done, because then it will make your life and their life a lot easier in controlling their blood glucose. You just have to accept at some point that this is the limit of your medical optimization. And at a random target that we're kind of trying to achieve in terms of safety is 75 millimoles or less than 9% in HbA1c. But as I say, if you cannot achieve it, but you think the patient will benefit, I think you should go ahead. This is now what I have spoken about is before bariatric surgery. Let's now talk about after bariatric, and more specifically, let's call it now metabolic, sticking onto the diabetes aspects. This is the data, the 10-year randomized controlled trial data from Geltrude Mingrone's group, which shows that with time, the percentage of people that have diabetes remission after even the biliopancreatic diversion and the Roux-en-Y gastric bypass gets less and less, or gets less and less. And that is not a failure. This is still an excellent result and much better than what I can do with my pharmacotherapy. And it just demonstrates the progressive nature of diabetes in the majority of patients. So the question is, if the patient is not controlled from a glycemic perspective, what can you do? So this is a trial that we ran at Imperial a couple of years ago. And what we did is we took patients that have had either a gastric bypass or a sleeve gastrectomy, but they had the residual type 2 diabetes. And we said, if we give them more pharmacotherapy, will it work, and how much will it work? So we gave them liraglutide, 1.8 milligrams versus placebo in a double-blinded, as I said, placebo-controlled study. And what we found, interestingly enough, was that liraglutide improved the HbA1c by about 1.1%, even in people that have had an operation, and it reduced weight by about 6%, which is exactly what liraglutide does in people who have never had an operation, in unoperated people with type 2 diabetes. So it is as if almost liraglutide didn't realize that the patient has had an operation, and it still worked. So, and another piece of evidence comes with regards to the combination now of surgery with medications, comes from this beautiful RCT that was published by Said Ikramuddin in 2018, which is 5-year data, which shows that if you combine pharmacotherapy with the gastric bypass and lifestyle modification, you get really impressive improvements in every marker you can think of: HbA1c, blood pressure, LDL, and weight loss. And what I was saying yesterday, and I'm repeating it today, is that I love the title of this paper, which is Lifestyle Intervention and Medical Management with or without the gastric bypass. It's not the gastric bypass versus intensive lifestyle. It is with or without. And that kind of gives us me the concept of using surgery as yet another pill, so to speak, in those people that have type 2 diabetes, a very effective pill, and one that I can combine with other medications. This gave rise to this comment that we made to Nature Reviews about the new gold standard, which is the medical gastric bypass. Again, going on to a bit practical questions that I get asked about the management of type 2 diabetes after surgery. So the way that I see it is that everyone that manages that after surgery should not be confused and should not be anxious. We make things look, we diabetologists make things look very complex, but that's because we want to be seen to be smart. But actually, they are very, very simple. So assume that when a patient has had a gastric bypass or a sleeve, that the surgeon has pressed the reset button to someone's diabetes. So they have reset them back to factory settings, let's put it that way. And they are presenting to you as a new diagnosis of diabetes. And then what you do is you treat them in exactly the same way as you would do with someone that has never had an operation. And what that means is that there we are again, exactly the same slide I showed you earlier on, which is you use any of these medications in exactly the same way as you would in someone who is unoperated. When it comes now to early on after the operation, how do you manage the patients? Well, then things are tough because you cannot predict what will happen to the glycemia. So you need very frequent contact if you want to get this right. And that means usually having a diabetes nurse, as we do, and we're lucky to do that, take charge of that. What I do, that's my own personal practice without much evidence, is that I don't use SGLT2 inhibitors in the first 3 months after an operation because I'm a little bit worried about the risk of ketoacidosis because everyone is the negative energy balance and so on. But what I do after 3 months is in people who have got established heart disease, I restart the SGLT2 and the GLP-1 independently of the glucose, which might be completely perfect because these agents have been shown to improve cardiovascular mortality and morbidity and kidney outcomes independently of glycemia. I've shown you in this slide. Now, if you want now to cause weight loss after these operations, at the moment in the NHS, you don't have much. But there is no reason why you cannot, in the future, use exactly the things that you're using before surgery. Any of those agents that I have presented, because they are available, small amount of evidence suggests that they work equally well. So this is just an example of this evidence that comes from Canada of about 117 patients or so that had a bypass, the band, and the sleeve gastrectomy, and then they were given 3 milligrams of Liraglutide Saxenda, which is not available in the NHS for after surgery. It's only available before surgery. And what you'll see is the effect of Saxenda. Take, for example, the sleeve patients. What you see is that the weight loss that they achieve is, as I was saying earlier on, almost exactly the same as to unoperated patients. So we've talked about type 2 diabetes and obesity before surgery. We've talked about type 2 diabetes and obesity a little bit after surgery. And as I say, I think you need to consider surgery not as an isolated event, but as part of the continuum for the management of these two conditions, which are chronic, and they generally are unlikely to go into remission. So you need to keep the pharmacotherapy going in those that need it. Thank you very much for listening, and thank you to my colleagues that have helped contributed to this work. Thank you very much.
Fantastic, absolutely brilliant. Thank you very much. We already have one question from the delegates, and this comes from someone called Lindsay. And it is, how well are the side effects tolerated with combined therapy?
That's a great question, because you start wondering, if I give someone a GLP-1 after an operation that drives this GLP-1 anyway, number one, will they get very sick in terms of nausea, or could they get pancreatitis? And the answer is that in the available evidence we have from our randomized controlled clinical trial, it is that it is tolerated in exactly the same way as it is tolerated in someone who has never had an operation. So which is reassuring. And we've also, at least in the 6 months, but now we have got longer follow-up that has not been published, we are not seeing any evidence of increased rates of pancreatitis. So very safe drugs overall. I think we should be using them a lot more.
Fantastic. And so one of my co-chairs, Dr. Kopak, is having a few technical issues, but I believe he does have a question. Simon, are you able to communicate with us?
Alex,
okay.
I've got Adrian Brown asking a question. What do you think will be the impact on surgery commissioning if we now have medications that generate 20 to 25 weight loss? Super question. And as we did yesterday, I want to reassure my surgical colleagues that they will not be out of a job in the near future. In fact, I think that you will be operating more than what you're operating now. Because what's happening is that with all of this pharmacotherapy, it means that more people will come to the obesity clinics across the country. And in fact, well, let's talk about the UK. Across the country, more people will come. And therefore, the drugs will work in about, depending on what you look in terms of classifying how does it work, how much it works, in about 70% of patients, all right? So you're left with 20 to 30% of people that will not respond to the medications. And what is the obvious next step? The obvious next step is surgery.
Mr. Alex, your voice is muted, I think, or your voice is not audible. Can you check?
Yeah, my apologies. So we've got a question from Simon Kopak. I don't know, I hope you've heard most of my answers to the previous question. Did you? Yeah, good. Adrian is happy, which is good news. So Simon is asking, have you had any resistance from GPs or patients in taking GLP-1 and SGLT2 in patients whose diabetes has been improved with surgery? Absolutely. I have resistance and I have to fight. But you know, and GPs are not they're not the barriers usually. Usually it's a pharmacist that says, you know, we shouldn't be doing that because according to Rule 25B, that's not shouldn't be done. And the answer, so what I say is that I strongly feel that this is the right thing for the patient, that reassures the GP, and I would say that in 70% of cases, what I suggest happens. There is a 20 to 30% failure rate, but what can you do? You cannot have everything.
Okay, we've got 3 more questions from the floor. So one is from Lindsay Parry, who's asked, this is a really interesting area. How well tolerated are combined drug therapies in your experience?
Well, it depends whether you mean before and after surgery, and it depends what combination therapy you're talking about. Okay, so let's talk about what we have at the moment. At the moment, in the absence of bariatric surgery, we have the combination of GLP-1s and possibly the only other medication which is available in the market, not the NHS, which is naltrexone and bupropion, i.e. Mycimba. Very few studies have been done in the combination, but they seem to be safe, and because they work through different mechanisms, you might get a little bit more nausea, but I have used them rarely, and my experience is that they are okay. But I don't want to talk about that too much because the evidence is pretty weak and mostly anecdotal. But what seems to be working very well is the combination of gut hormone therapies. So we now have got the combination of GLP-1 with amylin, that is being investigated, that should come out by 2025, and also the combination of GLP-1s with GIP, which has shown amazing results this year. So great potential and great safety.
Brilliant. Guy Holt has asked another question. Do you think that a patient's response to GLP-1 therapy may provide an insight into how they may respond after bariatric surgery?
That's a great question. Really good question. So I'll tell you two things about that. In rats or mice, that is indeed the case. So when you give GLP-1 to mice or rats that have diabetes, that can predict the response to a gastric bypass in rats in terms of glycemic control. So that's one good piece of news. Some work from Birmingham, a very small sample size, I don't think showed too much in terms of a correlation. So I was lucky because I got Novo Nordisk to provide us Saxenda for free before it came out in the NHS as part of a free of charge program for 150 patients during the pandemic, so when they were not being treated. So I gave them Saxenda for free, which is great, and I'm giving it to them for about a year. And now I'm following them up after their surgery. So this is very much real world data, and it's a good sample, about 150 patients. So I may be able to have the answer for you at some point, but not yet.
Brilliant. And another question from the delegates, one from Vanessa Osborne. Is there anything we can do to reduce side effects of semaglutide?
Yeah, okay. That's a good question. And what I try and do in all of these medications is I try not to over medicalize things. So I don't want to be giving medications for the side effects of GLP-1. So like antiemetics or things for loperamide for diarrhea. So what I do is I just say keep very simple lifestyle advice. Keep hydrated, eat small meals, and if you are constipated, take more fiber and so on. So because I want to keep things as simple as I can. And also remember, if we're giving medications that counteract some of the effects of the medication in terms of gastric emptying, for example, it's not always a great idea. But yes, sometimes. Oh, and the second thing to say is I tell the patient that in 90% of people, these side effects will be temporary. They will be transient. So just be patient and they will go. If they carry on being there, then only then I would consider pharmacotherapy. But usually what I do is I reduce the dose or stop them.
Brilliant. Thank you very much. I don't think we have any more questions from the delegates. Oh, we do. One from Adrian Brown. There you are.
Very good
about
question.
The cost of the medication.
And I will give you exactly the same example I have been giving this week. So at the moment, bariatric surgery is the most cost-effective thing you can treat your patient with. Drugs are expensive and they will continue to be expensive for a little bit, and they have to be taken lifelong. So they are not, the majority of them are not cost-effective. But remember that when proton pump inhibitors came out, or ranitidine, to patients back in, I don't know, was it 80s and 90s, right? They were expensive drugs. They were not cost effective. You had to see a gastroenterologist to get them. You needed to have endoscopies done. So the NHS made it difficult for you. And now what can you do? You can go to the pharmacy and go and buy esomeprazole for a few quid, and that's it. As simple as that. So what will happen is these medication prices will go down with time because of patent, but also because NICE is pressurizing companies. Say, if you can get your medication, if you cannot get your medication through NICE because cost effectiveness, you are not going to come in. So you have to play with your prices as a company. And indeed, Novo Nordisk gave a very generous discount to the NHS for Saxenda. So our system, the NICE system, which serves as a model to many other countries in the world, is bringing prices down actively.
Brilliant. We have one last question, which is, we have endless discussions about medication absorption post-sleeve and our IHP. Yeah, when should we, and bypass, when should we really worry?
Never. I've been hearing this for many years, and I'll tell you that if you look at some of the pharmacokinetic studies, depends on what medication you are referring to. But people are taking diabetes drugs, they're taking immunosuppressants, so anti-epileptics, right? If these operations were causing problems with absorption, we would be seeing people having fits right, left, and center, or rejecting their grafts and transplants, or having terrible problems with depression and so on, or their mental health disease. The fact that we don't see that is very convincing real-world data that the absorption is perhaps a little bit, the absorption problem is a little bit of a myth, and I'll stop there.
Okay. One last question is, do you think the use of therapy will alter patient behavior long term, particularly in a negative way?
In what way? Why in a negative way? I think it depends what you mean by patient behavior. I think that surgery, I don't know if it means after surgery, but surgery is a biological treatment for the biological disease of obesity. Medicine is a biological treatment for the biological disease of obesity, and they work by changing behavior. So that's what we want them to do. So I don't see anything negative to that, but I might be misunderstanding the question.
Okay, well, you're off that one because I think we've just got to the end of the half hour. So I'm going to pass over to Sarah to introduce Adrian.
Thank you.
Thank you very much, Rachel. It gives me pleasure to introduce our next speaker, Dr. Adrian Brown. Adrian is a National Institute for Health Research lecturer and research fellow at the Center of Obesity Research at University College London. He is a senior specialist dietitian with over 15 years of clinical experience. He is also a PhD in medicine from Imperial College London. Over to you, Adrian.
Thank you very much for the wonderful introduction, Sarah, and thank you very much for inviting us to give a little bit of a talk today around weight terminology. So today I'm going to be presenting some of our data that we published last year that looked at weight terminology. Without further ado, I'll start. So I've got no declarations. So what I like people to do is I like people to get their phones out and use the QR code, because maybe we can come back to this later on. I would do this if we had a little bit more time. But what I'd like you to think about is I would like you to think about what emotions do you want to feel when you see a healthcare professional? It's a really important question to ask, because ultimately when I've asked this question in the past, the answers I get are optimistic, positive, hopeful or hope, not feeling blamed, safe, but ultimately supported. Now, unfortunately, people living with obesity that come to clinics, whether that be even clinics with specialist clinicians in obesity, can end up not feeling this way. And why is this? And I'm sure you're all aware now of something called weight stigma, which is the discrimination, bias and stereotyping based on a person's body weight. It can lead to negative stereotyping with attitudes, thoughts that people are lazy, that they won't stick to their plans, that are often very untrue. What we notice is that these are highly prevalent in multitude of areas, whether that be media, education, workplace, but unfortunately, even healthcare. So these are some comments about people living with obesity from healthcare professionals when asked. Non-compliant, weak-willed, poor self-control, lazy, unsuccessful, and dishonest. These are comments from people that are meant to be helping that person. And what tends to come through is that these feelings of weight stigma can really drive patients actually not attending their appointments and actually not actually continuing with lifestyle changes. So a really important aspect. So what do we know so far about weight terminology? As you'd expect, we know that poor communication with people living with obesity can impact on engagement, motivation, and the patient-practitioner relationship. When we start actually looking at the data related to preferred terms, because there has been some, what we notice is there tends to be a pattern of forming. There's very much a pattern that preferred terms tend to be weight, unhealthy weight, or BMI. But when we look at the data in both adults and adolescents, we notice that the words obese, whether that's linked in with things like morbid obesity, quote unquote, and fat, quote unquote, are universally disliked. Now, what we notice is that things tend to differ on a variety of demographics. We notice word preferences tend to differ with gender, ethnicity, internalization of that weight stigma, and also we notice that things change with body mass index as well. So it's important that when we are with our patients, we don't make assumptions about the terminology that we think they want to hear instead of the terminology that they wish to. So despite all this data, there's still ambiguity that remains, and particularly in the UK, we're still unsure really about those terms when you speak to people. One key factor and difference with the research that we did was really looking at emotional response. There's still a lack of studies looking at how a word actually impacts emotionally on the person living with overweight and obesity. Some data published in 2011 from Rebecca Poole looked at using stigmatizing languages and then asked people, adults, about terms to use their own body weight, and then parents the terms to describe their children, and they asked them how they would see them. And what they said is that if they use stigmatizing languages, around 41% of adults and 30% of parents on terms related to their children would feel upset or embarrassed. 20% of adults and just over a third of parents would seek another doctor, and around 20% in both would avoid future appointments. So we can quite clearly see that if we use stigmatizing language, this can significantly impact on patients engaging in care. So also from adolescent data, it does suggest, and parent data, it suggests that people would feel stigmatized, that words would be offensive, blaming, but also, most importantly, unmotivating. The words of using negative phrasing, such as quote unquote fat, doesn't motivate someone. So quote unquote fat shaming does not help. But when we look at evidence related to adults' emotional response is actually limited at the present time. So what did we do? So we, myself and Dr. Stuart Flint, who's an expert in weight stigma, did a study looking at preferences and emotional responses to weight-related terms from health professionals to body weight in people living with overweight and obesity. And I encourage you to go and look at this. This is open access in clinical obesity. So what we did is we had just under 3,000 people complete the survey, of which around 1,700 were actually living with overweight and obesity. The remainder were actually with a healthier body weight. Their mean age was around 49. There were about 96% females, 31.4% of the mean BMI. And what we asked is we asked their preferences related to 22 weight-related terms. And you'll see this on the right-hand side. So what we've got here is we've got overweight, quote-unquote obese, quote-unquote big, large, quote-unquote fat, obesity that's regularly used. Should we be using that? Weight, unhealthy weight. So really terms that we might see within the literature, but also what you might have previously used in clinic. We then looked at 7 core emotions. So these core emotions were happiness, contempt, anger, surprise, fear, sadness, and disgust. We also asked patients if they weren't sure, but also if they didn't mind. In addition to that, we collected modified weight bias internalization scale, as there's been suggestion, as I showed, related to the impact of that. The modified, the reason we use the modified is it can be used across BMI categories as opposed to the weight bias internalization scale. And then we did some regression to see what might be driving. So what did we find? So this is preferred and least preferred terms to weight-related terms for adults related to their own body weight. So what we found that seemed to link in again with what's been shown previously was weight and unhealthy weight came out as preferred terms, and then overweight as well. When we looked at least preferred terms, we had super obese, quote unquote, we had quote unquote chubby, and we had quote unquote extra large. So what you notice is that we've got terms there that might actually be used regularly when you go and buy your clothes. So extra large is something that's regularly used, that's an extra large, but actually these are terms that are not preferred. When we ask patients to parents of children about preferred terms related to their children, the preferred terms again came out as weight, unhealthy weight, but this time they preferred the word BMI. On least preferred terms, we had fat, we had quote unquote extra large, and quote unquote extremely obese. So again, this extra large seems to come through, but with parents talking about their children, quote unquote fat has come through as a least preferred term. But let's think about actually comparing it across BMI categories. Does it change if someone has a BMI of less than 25 compared to having a BMI of over 30? When we looked at preferred terms, we noticed that in terms of the ordering, so we have weight, both people living with overweight and obesity had preferred the same term, most was weight. When it went to second term, people of a healthy weight tended to prefer the word BMI, whereas people living with overweight and obesity preferred the word overweight. Now, what might this be? Now, some of the thoughts that we actually had were related to how BMI is termed in someone with a healthy body weight. So what this might term is that actually they've had positive affirmations. Congratulations, your BMI is under 25. You are in a quote unquote healthy range. Whereas people living with overweight and obesity might actually refer this to actually having negative connotations. Your BMI is X, Y, and Z, and therefore having a negative connotations by saying, actually, you should be losing weight. When we looked at parents, actually, there was no difference across BMI categories related to preferred terms. When we looked at preferred terms, least preferred terms, we noticed that it was the terms related to adults' preferences were exactly the same. It was just the ordering that was slightly different. So what you notice is that super obese tended to be the least preferred term, with adults living with overweight and obesity, and chubby in people with a healthy weight. And then that swapped over when we got to the second preferred term. But again, extra large was not liked. When we looked at parents, what we noticed is patients with overweight and obesity, their third least preferred term was for obesity, was actually extremely obese. And what we noticed is for overweight, that morbidly obese, quote unquote, was preferred in overweight. And the term curvy came in with the healthy weight. So some slight differences, but very subtle. This was really the novel aspect of what we did. We looked at emotional response. So generally, when we looked at all the terms, generally what we found is that they tended to have a negative emotional response. When we looked at adults, we found that sadness was the most regularly referred to emotion on all of the terms. But when we looked at parents, anger came through. So a slight difference in terms of how people are perceiving it, whether it's related to your child or it's related to yourself. When we looked at particular words, responses to words like morbidly obese, extremely obese, and also super obese, one key emotional response came out across all BMI categories, and that was the word disgust. And this aligns with some of the words that we see in the literature related to the impact of people believing that people living with obesity are, in quote unquote, it gives them disgust. When we started looking a little bit further at some of the terms that might be used with parents about their child, interestingly, the term high BMI actually came out with the word fear. We noticed that fear was tended to be more regularly used. So fear is typically a response when a person wants to have physical safety when they're threatened. But from the literature, it does appear that this fear might in part be related to parents worrying about the fact that they're actually being blamed for their child's weight. These understandings start to get us to understand about how there might be key differences between people, between their least and most preferred terms when we start thinking. But further on from that, when we did further analysis, one of the most interesting things that came out was when we added adverbs, there seemed to be an increase of negative emotion, particularly around disgust. So what we found is high BMI versus BMI had increased levels of disgust, the same with extra large versus large, and also with very overweight versus overweight. So this really sort of indicates that we've got adverbs that actually can intensify the emotional response. And it's interesting to think that actually some of these terms that we use, you've got a high BMI, might actually be having a more negative impact on people living with overweight and obesity. What we believe is happening is that these descriptive adverbs, these exaggeratory adverbs, are actually moving people further away from the social norms that they have, and they're feeling less in quote unquote normal. So it's important to understand what's happening. And this really goes down to the fact that we've got to think about our language. Now, this word, quote unquote, severe obesity, is now regularly being used by medical organizations to describe someone with a BMI of over 40. However, if adverbs, when we're describing people, are actually causing negative emotional responses, should we as a community be thinking about alternative phrases? Let's start to think a little bit about factors that might actually be impacting on body weight, on these weight-related terms. We found that there was a relationship, although weak, related to weight bias internalization and BMI. So that for every additional point in BMI, there was an additional only 0.3 point increase in weight bias internalization. But what we noticed is that there actually were factors that were impacting on either liking or disliking. And these, similar to what we found, what I reported previously, were age, BMI, etc. So what we found is that younger people had a stronger dislike for extra large, quote unquote, super obese, and quote unquote chubby. And what we found or suggested is that this might be related to younger people being more self-conscious about body image and appearances compared to people of older age, as we see and come out in other literature. When we looked at BMI, this had less of an effect on liking and disliking. However, when we looked at unhealthy weight, this tended to be less preferred by people with a higher BMI that might reflect some sort of perceived threat or fear. And what we noticed is that unhealthy weight actually was preferred with people with more with higher internalization of stigma as well. So this might actually suggest an internalization of the people is stronger with the word overweight. I might be preaching to the converted, but we should all be starting to think about, as we say in our paper, about person first language. This is obviously putting the person first before the condition. People are not defined by their health status, as we're fully aware, but it's so important that if we see this happening, we challenge people, whether that they be in our specialism or not, around this topic. So as many of you will know, we don't call someone quote unquote an obese person, people, they're people living with obesity. It's not the woman is obese, it's the woman is living with obesity. Now, if you are unsure about weight terminology, what I would suggest you do is ask the person what terms they would prefer to use if they are in front of you. Don't assume, and I'm going to give you some a few phrases in the next slide that might help you to start to think about that. So that's very much concluding sort of the ideas about terminology. So what should we be doing from now? What we know is that language has an impact on the relationship that we have with people living with obesity. We should be careful that the language that we use might not have that might have unintentionally communicate bias, blame, or negative judgment. We need compassion when we're discussing body weight, not blame. If we look at all the literature and we bring it together, weight seems to be a uniformly preferred term and might be something to consider when we're initiating those discussions about body weight. Weight-related terms, it doesn't matter which one, tend to find that they have negative emotional responses and that we should be looking to avoid these exacerbating adverbs, things like extreme, high, and super. Language should be supportive and empowering. We need to recognize that there's a diversity in preferences of language across BMI, across age, and potentially around internalized weight stigma as well. But ultimately, we should be asking patients around their preferred terms. A way that you could do this is when we initially see patients, even if they are referred to us for bariatric surgery, is say, could we talk about your weight today? Gain permission to ask to talk about it, as it therefore opens up the conversation with the patient. And ultimately, it's then saying, what words are you comfortable with when we're talking about weight? So very much opening and asking the patient, what terms would you prefer, to identify about preferred terms or not. As some people might actually prefer terms that might be considered from our data stigmatizing, but actually would prefer them to be used when describing their body weight. I thank you very much. I'd like to acknowledge all the people that helped with our research and distribution. And I thank you very much. If you want to follow me on Twitter, I'm at BrownAD, and any questions, and I will stop sharing my screen.
Oh, well, Adrian, thank you so much for such a brilliant talk.
Thank you.
And I have to say that your talk has generated a lot of interest, and you know, we've got a number of questions that have come through for you.
Yeah.
So the first question, Adrian, is from Dr. Kopak.
Yep.
And so Dr. Kopak says that of the terms you mentioned, the one I use most is non-compliant. And that is usually in the context of CPAP usage.
Yeah.
Often I do not have any information about why the patient is not using. How can I convey the idea of CPAP non-compliance? And then he adds, I'm talking about what goes in letters to the GPs copied to the patient.
Very interesting term. I'm not a fan of the word non-compliance. It suggests blame. And I think what we need to do initially is we need to speak to the patient to actually find out what's happening and find out the reasons that they might be struggling. Clearly, something's meaning that they might be struggling with their CPAP. So the initial period that I would do is I would find out from the patient and reframe it back and say, okay, it looks like from the CPAP data that you might be struggling to actually use the CPAP. Can we have a discussion about it, please? And then find that out. Then what you will do is, I wouldn't use non-compliant. I would use more neutral terms around, the patient has reported to me that they are struggling to use the CPAP machine, and we have had a discussion in X, Y, and Z. I think I would avoid the word non-compliant and the ideas of blame, as we were saying in the final slide. A lot of blame happens, and people will unlike. There's a chance that if people have stigmatizing language, they might look for another doctor, or they might not come back. And so I would really reframe it onto the patient, and then look to use more neutral language. I hope that answers your question.
Yeah, thanks, Adrian. So there's another question from Dr. Kopak. So yeah, so very interesting. Diagnostic labels from our electronic medical records are often automatically added to patient letters. Yep. These records have lists of coexistent diagnoses, and severe obesity would be in that category. Mm-hmm. So how could we cope with that?
I think we need to check our letters and alter them. Ultimately, and change them at source. I know they automatically cover, but it's our responsibility with our letters. This is my personal opinion. Is that we should be looking at making sure that the language that we use is different to is making sure that it's non-stigmatizing. I do appreciate it can be incredibly difficult. However, I think that if we are looking at those sort of aspects, we should be very mindful of the language, that if we know it's going to be copied over, that we speak to secretaries, we speak to our team, and we check them to make sure that the stigmatizing language is altered. If there's a way of changing it at source, I wish there was, but I'm not part of that team, and I'm not sure if any of the panel, Sarah or Rachel, might know if that's possible at a more source level.
Well, I have to say, I mean, it's going to be very, very, very difficult. So a few more questions.
Yeah, of course.
Yeah. So Vanessa, I mean, she says, thanks, Adrian, for another fantastic talk. Can I ask, how can we use internalized stigma as an outcome measure? Are there any validated tools we can use in practice?
That's a really interesting question. And yes, there are validated tools. The tool that we had in there, which is the weight bias internalization scale, can be used to identify if individuals living with overweight and obesity have internalized weight bias. So that can be used if you're looking across more BMIs. So, for example, if you're looking at healthcare professionals or people with a BMI that wouldn't be wouldn't be for a person living with overweight and obesity, it would be the modified version, and that's the version that I presented today. So you could potentially use those as outcome measures. The thing with it is that internalized weight bias, what are we doing to try and help with internalization of weight bias? And I think some of these will very much be based about our language and how we conduct ourselves as healthcare professionals in people living with overweight and obesity, and how we have those discussions with people. So avoiding blame, having open discussions with people. And often when we look at weight regain, it's often people look at the patient first and say, what's happened to the patient? The patient's clearly not followed my advice. The operation's fine. It's something that they've done. And I think we need to be looking, obviously I know that things have changed significantly and we look at operations as well now as well, but I think we need to be very mindful of how we're going in about that. But very much terminology would be the first step. There are training ways that we can start to look at our own internalized weight biases related to that. And an excellent talk by Rebecca Poole actually last week looked at that and very interesting outcomes from that. So yes, hopefully that's answers your question.
Right. So next question, Adrian, is from Sophia. Well, she starts by saying, brilliant presentation, Adrian. So the quick question is, I know that it is common for populations in studies like this to have a high female participant rate compared to males. Would you ever consider doing a similar study in a male population? And then she adds, it would be interesting to see if their liking and disliking would be similar to females, who might be slightly more sensitive than males. Well, I will have to agree on that point with Sophia.
It's a good point. Obviously, when we put out the survey, as you'll all appreciate, because you work in weight management, the majority of people that come to weight management clinics tend to be a female. It is a limitation of this study that it was predominantly in female individuals. We didn't have enough men to therefore compare. It would have been an unfair comparison. As you saw, we had 4% men. Is there a possibility that there could be differences from previous data? Yes. We noticed that there is changes in terms of potential preferences and emotional responses. We don't necessarily have that data. And yes, I think in the future, we will be looking at some more data related to that. We do have agreement. We have the availability to do some open-ended question data, so semi-structured qualitative work, which we're hoping to do, and hopefully we'll be able to engage with some men in this situation and get a sort of more equal balance than we got in this survey. But this survey currently is the largest one that's being done in this area. So we really hope that we're starting to get to a point that we're actually getting some really strong evidence around some terms that are really not preferred and some terms that are.
Well, Adrian, 2 more questions, and then we can let you go. We can let you relax. First one is from Michael. Would you discourage the use of obesity classifications? For example, class 3 obesity within the use of correspondence, or is this acceptable within this context? A quick response, please.
It's a really interesting question. At the present time, I don't think we have the data for it. I think it's going to be something potentially in the future around how we might be able to define obesity, not using different terms, because I appreciate the word quote unquote severe obesity that we're using ubiquitously now might not necessarily be a phrase from our data that might be preferred by people living with overweight and obesity. So I think in the future, we need to start to think about maybe some other terms. And I think further research might look at this, yeah.
And then Ciara asks, how can we influence colleagues in primary care and other areas who still use stigmatizing language?
I think one of the biggest things is to challenge them, attempt to educate them. Please share our study. There was a systematic review by Rebecca Poole last year looking at the same terminology, but also the consensus statement, the international consensus statement that was published in 2020 on World Obesity Day, really identifies around the use of language, but also in addition to that, around ways that we can look to reduce down stigma within our areas. So I would encourage you to please share that information with you. But the first step is to say we know stigma exists in our healthcare system, and if you see it, challenge it and say, do you mind if I share some new data around the way that we speak to our patients living with overweight and obesity?
Well, with that, I think we have to conclude this session. I would like to thank you, my co-chairs, Ms. Agrawal and Dr. Kopak, and a big thank you, a huge thank you to both Dr. Alex Miras and to Dr. Adrian Brown. Thank you so much.
Thank you very much, everyone.